let me just start while people write down questions if you have them, but can you offer any thoughts on the afatinib-cetuximab combination, your impressions of its activity and tolerability?
Yeah, so when you think of afatinib combined with cetuximab, these are two drugs that have rash as a pretty common toxicity or common side effect, and that's because they're targeting EGFR, so it kind of makes rational sense that that would be the case. I have to say that when my colleague William Pao did this experiment in the laboratory, I said, that's cute, but you can't do that to people. That's going to be awful. But you have to do the trial because the data looks good in the laboratory. And we were quite surprised to find out how tolerable it was. In truth, we had done the previous trial that you mentioned combining erlotinib and cetuximab, and that was actually worse than afatinib and cetuximab for some reason.
Did not have activity that was
didn't work
encouraging.
Exactly.
Right?
Exactly. So I think that's it's more tolerable than you'd expect. At the same time, it's not as tolerable as, say, ruxolitinib or osimertinib, and so as a consequence, I think it's losing a lot of excitement in the resistance setting. It is being studied as an upfront treatment as part of the cooperative group networks, and so we will know a bit more about its activity and tolerability really soon.
Question comes in about which of the, I would presume, third-gen TKIs is superior for extracranial, intercranial disease, both. My sense is that, they certainly haven't been compared head-to-head, and they seem to be comparable. Would you agree?
Yeah, I totally agree, and we see they've both presented data of patients who have brain metastases responding to treatment. We don't know particularly well if one is better than the other, and I think that's really only going to be borne out over time.
So let me just share one thing that I don't know if you have heard of or had the occasion to pursue, but Dr. Sequist shared with me that she has had a few patients go from the ruxolitinib trial, Tiger-X, to subsequent treatment with AZD92 with osimertinib and do well. And I wouldn't consider that an intuitive finding, that we might presume that there's a lot of cross-resistance between them. I don't know that this is necessarily a strategy that everyone should start with ruxolitinib and then move on to salvage with osimertinib, but the concept that there could be meaningful activity to treating sequentially is at least provocative.
Yeah, and potentially exciting. No, I think so. I've had a single patient who received initially ruxolitinib, followed by osimertinib, and did well. She was in a very difficult spot when she developed resistance to ruxolitinib, but with the addition of osimertinib, she actually had significant shrinkage and disease control for several months. You're right, a priori you wouldn't think this would happen, but at the same time, we're just beginning to understand how tumors become resistant to these drugs. And we know that for AZD9291, the most commonly identified mutation at resistance is something called C797S. There has not yet been identification of C797S as a mechanism of resistance to ruxolitinib. And so there may be different mechanisms. You would think they both bind in the same place and they look pretty similar, that they should be the same, but it doesn't seem to be that case.
Question came up about what happens with mixed response to a first generation or a first line therapy. And it's interesting. I'm interested in your thoughts on, would you be inclined to ever continue with the first line therapy? How much does it depend on the balance, the volume, and what's available in the background? Yeah. I guess would you have a different threshold for changing if you sampled and found T790M or not?
Right, and it's always about how mixed things are, right? Mm-hmm. And so we often see situations in which patients have, say, a single adrenal metastasis that seems to continue to grow while everything else shrinks. And in that context, I kind of approach it like the acquired resistance type thing, where you'll consider radiation or a surgical resection of that single growing site if you have the other sites shrinking. And I think that's a reasonable approach. I think biopsying it to find out what's going on is also reasonable. But I think sort of other situations which you'd say describe as a mixed response is, the 3 lesions in the lungs are shrinking, but the 6 lesions in the liver are growing. And I think in that context, we have fewer options with regard to some sort of local treatment, and so you have to really change the systemic therapy and pick a new chemotherapy.
But there, again, first of all, it's important to underscore that mixed responses are common.
Yeah.
But as you said, how mixed? I mean, you could have the vast majority of the cancer be in the chest and responding really well, and if you had one new bone lesion, you would say, oh, let's just radiate that for symptomatic benefit anyway, and continue on with everything we're doing to control the other 90% of the disease. On the other hand, if you had a few mediastinal nodes shrinking, but a large amount of liver disease growing, you would say, a little minor victory, but let's move on to something else. So it really depends on that balance of how much is growing versus how much is shrinking.
Yeah, and I'll say, you asked, what sort of volume criteria to use. I use what we use in research studies to help me in this situation, and that's what you do is you just add up the length of all the tumors in you, and then you figure out overall things growing or things shrinking.
General question comes in. It's maybe not necessarily for acquired resistance, but I think relevant today. How would you treat exon 19 or 21 differently or not?
Right. I don't treat them differently. I treat them, my standard first-line therapy, standard first-line EGFR TKI is the same, whether the patient has 19 deletion or LA58R.
Okay. Do you feel particularly strongly about which agent?
I do not feel strongly about which agent. I have one that I feel comfortable with, and my nurse feels comfortable filling out the paperwork on, but there are, to my mind, I wouldn't say that there's a significant difference among the 3.
Yeah, and my sense is certainly there's some spectrum of opinion, but there's a lot of lung cancer specialists who favor or more kind of TKI agnostic. I'm scratching my head about how clinically significant the exon 19 specificity might be for afatinib, perhaps, and the work on exon 18 is not the same at all, except it just suggests that we shouldn't broadly presume that these are all just identical drugs, and there could be differences. I think, fortunately, we have a comparative head-to-head trial that may or may not give us a definitive statistically significant answer, but will give us some semblance, more than we have now, of just cross-trial comparisons, which are very troubling. I will say that I tend to favor the combination of an erlotinib with bevacizumab, based on some of the data I showed, which is not specific to one mutation or another. That also is not something that the vast majority of oncologists are doing. Some are, but many are looking for more data. But to me, that the magnitude of the difference is compelling enough that leads me in that direction. And the fact that the benefit with bevacizumab seems to override any differences helps me reconcile that.
That makes good sense, and I think the more we haven't seen data that says the combination of erlotinib bevacizumab is worse than erlotinib, and we have multiple series suggesting EGFR TKI plus bev is better. And so I tend to support that.
General question about EGFR TKIs and brain metastases. Do you feel that radiation is almost always the best approach for brain metastases, or do you feel that there is an EGFR TKI with a specific dose and schedule that is a valid or even perhaps preferable approach?
So I'll say that for upfront treatment, so if I meet a new patient who hasn't been treated and has brain metastases and they have I know they have EGFR mutant lung cancer, I'm going to treat them with an EGFR TKI as my first step. I'm not going to do brain radiation as my first step. That's not what the textbook says for the most part, but I think that these drugs have a very significant activity in the brain, and as a consequence, I think that's the way to go, because we can potentially delay whole brain radiation for quite some time. But I think we have to be careful when we do that, because the response rate is not 100%, the response rate is less than, and if we are using radiation, the response rate approaches 100%. So yeah, I do it with some trepidation. It's easier when the spots are smaller. It's easier when they have fewer symptoms.
Okay. What are your thoughts on pulsed Tarceva? Is that an approach that you would think as a very valid one?
So we've been exploring pulse erlotinib.
And just to explain what that is, it's higher dose, commonly four pills or 600 milligrams every 4 days, or even 1,000 milligrams or so every week. So there's a common schedule. So instead of this one pill once a day, you just give essentially the same amount or something close to that, but stack it all much more intermittently, and then give a spike of it that could get into the CNS.
Yeah, so we've tested that in a lot of different ways, and we've actually made the spike dose really crazy high doses like 2,000 milligrams, or even we have an ongoing trial now where we give patients 2 days a week of 1,200 milligrams, followed by daily dosing at low doses. These are kind of cool ideas of how we can try to treat patients. We tried that strategy of using pulse dosing plus low dose as an initial therapy for patients with lung cancer, and we did not see any change in mechanisms of resistance, which is what we'd hoped to see, and we did not see a significant change in duration of disease control. And you'll be pleased to know that there was no difference in side effects, and maybe there were slightly improved side effects, despite the fact that they were getting these monstrous doses on a couple days a week. But one kind of curious thing we did see in that upfront trial is that we didn't see any patients progressing in the brain. It may have been a fluke of the number of patients that we treated, but it suggested to us that this may really work better in the brain, and that's the place a lot of folks have used this type of approach. We're now doing an upfront trial of patients who have known brain metastases and EGFR mutation, and trying this pulse dosing as the first therapy. Now, the other place that pulse dosing comes into use is based on handfuls of case series where patients who have some sort of brain-based lesion that's causing trouble, and we try high doses to get over that blood-brain barrier, if you will. And I have to say that I've been less impressed by its utility in patients who have brain metastases, but I have seen a handful of patients do extraordinarily well who have leptomeningeal disease. This is where the cancer involves the fluid around the brain. And in those patients where the fluid is affected, they have a variety of symptoms related to the cancer, and this approach can sometimes help with those symptoms and actually lead to long-term disease control.
Well, I think that's really where that approach has come into its own. It's still not well documented, but many of us have a handful of cases that have done far, far better than we would have otherwise expected to see, which is it's a very vexing, challenging problem when you see that. So, question of a patient who is, or a friend who is getting biopsied after progression on erlotinib, Tarceva. If T790M negative, what would you recommend?
So when patients are T790M negative, I often consider a variety of trials, but I have to say that in the absence of a trial, I would give chemotherapy plus erlotinib in this setting.
And continue the erlotinib.
Yeah. Okay. And I think that data that you referenced from IMPRESS for patients who are T790M negative confirms my biases that I think it's a good approach, and so I would continue it.
Just for backstory, I mean, there's been a lot of still confusion, ambivalence, debate about whether concurrent therapy makes sense treating beyond progression or not. And after these data were presented last year, around this time at a different meeting, but without the subset breakdown, it seemed that while a good idea that many of us followed intuitively, that concurrent chemo and EGFR inhibitors seemed to be not a good thing. And I wondered whether this breakdown by T790M positive or negative would lead to a change. And it sounds like for you it does.
Yeah,
Presumably you'd be far more inclined to do a third gen TKI if positive, right?
Right, absolutely. And I think you don't want to hear this probably, but doctors have their own biases about how they interpret data, and my bias has always been towards concurrent use. And so with this data, with this recent subset analysis, it kind of confirms my idea that concurrent is better because we don't really have enough data. And so I think based on what we have, I like the idea still.
I think it's a good point to make, that the reality is that everyone has different thresholds for when to change their views based on new data and how much data do you need. And for instance, I mean, I already said that I tend to favor adding bevacizumab to first-line Tarceva, but that's not what everyone does. And some people say, well, it's from Japan. We don't have data outside of Japan. It's only 152 patients. It's not that large. Some people believe or are not as inclined to believe afatinib is different from other drugs. And so, there's plenty of room for individual judgment. And of course, patients and their caregivers have differing views of how much evidence you need to go to a naturopathic approach or try cannabis oil or something like that. So I think it doesn't matter, honestly. The reality is that everyone comes in with our own biases, and docs are not different.
Right,
yeah,
absolutely.
Other questions coming in, or I'll have a few more. One of the questions that actually came from this morning is any recommendations to keep energy level up. I will say that I think that the main, to me, as I betrayed as a general strategy, is not to over-treat people. I mean, if you can treat people with less and they'll do just as well, that's a fine idea that applies, not necessarily to give combinations if one drug will do it and if a less toxic drug will do it. Most is not always best. And then obviously, we push people to be as active as they can comfortably be. We try to keep people eating well and generally keep weight stable. I don't tend to get too fancy about my recommendations about vitamins or specific diets, just basically to say try to have a broad diet, multivitamins okay, but high doses maybe not. What advice do you give?
Well, I think the challenge is manifold, really, but let me focus in on the patient who doesn't, who tells you they're tired and talks about that as a symptom, but and understands in a sort of general sense that it may be treatment related. I think I struggle with a lot of patients who I say, this is probably treatment related fatigue. You're tired because of the treatment, and the idea of reducing the dose or holding treatment for some time is sufficiently scary that they don't want to try that approach. And I think that's a hard situation to be in, of course, but I think we do have to explore the idea of reducing dose or taking a break during treatment so that we can deal with that. I had a patient recently who was on pemetrexed, which is a chemotherapy that can cause side effects. I'd worked with him a lot about spreading the doses out a little bit to give him a little bit more time. And then, one day he came in and said, Doc, you've been suggesting this for a long time, but I think I want to take a break from the chemotherapy. And so he's taken a break, and the first scan after 3 months off treatment showed the cancer hadn't grown, and that's the sort of thing that we have to explore. So I think you're absolutely right to avoid over-treatment as best we can. The other situation that's, I think, challenging is when patient develops progressive fatigue, where they really feel like it's changed significantly over, say, 2 months or less. And again, you have the challenge as to whether this is treatment-related to fatigue, but also in the back of the mind of the doctor is, is this cancer causing more trouble that we're just not seeing on CAT scan? But I think my approach is definitely to try to reduce the treatment as my first step, because that's one thing I can control. And I think that's our best approach.
Yeah, in that sense, it's a diagnostic test. It's not uncommon to have symptoms that could be from the cancer, could be from the treatment. One way is to take a step back, stop the medication, and see if people are getting better. It's overwhelmingly likely that it's treatment related. If it's getting worse, it's cancer related. And just along the lines of meningeal carcinomatosis, to me that is one of those hard ones to, you can go a long time and it can evade diagnosis, but to me that's one that I always try to remind myself whenever you have somebody who's doing and feeling far worse, but their scans don't explain it, that's often the case.
I wanted to add on to what you mentioned about exercise, and I think when I talk with patients about exercise and talk with them about what to do, I can't tell you how many patients who I talk with, I just say, you got to walk. You got to go out and walk every day. You got to walk longer the next day than the day before. And everybody who actually does it comes back and says, it actually helps. So I can't emphasize that enough.
I want to come back to the issue of breaks and EGFR inhibitors. And that is, I sometimes have patients who say, I've been on this for 6 months, my disease is well controlled, or I don't see anything. I think I'm cured. What do you think about me stopping this? And I highly recommend against that. That just because you don't see it doesn't mean that the cancer's gone for good, and that we usually see, and in fact you've written on and described the flare issues, that we would prefer for people to be on these therapies if they're tolerating them, with an understanding that it's under the surface and likely to manifest itself readily if you stop it. But at the same time, the other extreme is also dangerous, that if you have a terrific rash or rip-roaring diarrhea, it's okay to take a week or two off and then lower the dose. That it's not that the cancer is going to, in almost any case, explode. It's really worth not overdoing it, but at the same time not stopping just because you're tired of taking a pill.
Yeah, I think that's a great point. And I think, so when we look at laboratory models of resistance, a fast way to develop resistance is intermittent therapy. So you give a treatment for 2 weeks, you hold treatment for 2 weeks, give it for 2 weeks and hold it for 2 weeks. A much harder, you don't get resistance if you just give a lower dose continuously. And so the way that manifests in patients is there's no sense in toughing it out if the side effects are too much, because our goal is long term. Our goal is, controlling the disease for as long as possible. So when I'm thinking about the dose of a given therapy for a patient, I want the highest dose that's tolerable. And the key is that it has to be tolerable. It has to be something they can imagine themselves taking for the next year, 2 years, 5 years. That's what our goal is, and that's where we should go. Everybody's threshold for tolerable is different, but I think that's where I set it.
And that's a good point. I mean, I tell people that if they can suffer through it for another couple of weeks, that's not really good enough. The value of this is these are really meant to be longitudinal therapies, but they have to be tolerable on that basis. So. And then any other is there any setting in which surgery for brain metastases would be valuable at this point?
So we relatively routinely use brain surgery for single lesions that are on the larger side, and particularly for lesions that are large and causing symptoms. So we're big fans of surgical treatment, and believe it or not, probably some people in this room have had brain surgery for lung cancer. It's not as bad as it sounds.
To us.
For those patients who've had surgery for lung cancer, so a lung surgery, and those patients who've had subsequently gone on to have a surgery for their brain spot, they always say that the brain surgery was 10 times easier than the lung surgery.
And then finally, I don't know if this came earlier in the day, and I don't know where it would fit, but someone was asking about the possible efficacy of hyperthermia in cancer treatment. Is there any, and particularly they thought that they'd seen a UK-based trial that reported on this. Do you have any comments about hyperthermia, probably not specifically to driver mutations, but just anything?
Yeah, so hyperthermia has been most explored in the setting of instilling chemotherapy into the chest cavity, typically at the time of surgery. You know, I'll give you my bias, which is it sounds kooky, and I can't imagine it would work. But that's sort of been where it's been most explored, and it's been explored in, you know, places you've heard of, like, you know, Harvard and places. So it's not so kooky to everybody. But I've never seen anything that convinced me that it's something I thought would make sense.
I would say a limitation of that, as well as all sorts of things, whether it is radio frequency ablation. I mean, these are all limited by, you have a problem that whether you can see it or not is a whole body problem. And so focusing obsessively about one area, and you know, hyperthermia can't be done everywhere. It's usually a very directed treatment approach, is not, you know, it's not going to fix the problem if you have cancer cells circulating wherever they want to land. Right. I guess theoretically it might be that you could stimulate the immune system or something like that, but we're a long ways from having our local therapies integrated with immunotherapy with the thought of kickstarting a systemic immunotherapy response. Yeah. So thank you all very much. We're going to take another break and reconvene here at 2:30, and so there's coffee and refreshments outside and sunlight. Okay, take care.